Dear chairpersons and colleagues, I would like to thank the organizing committee, especially Dr. Gülsan, for inviting me to this special conference. I'm here today to talk about changing epidemiology and burden of the Crimean Congo hemorrhagic fever. I have no conflict of interest in relation to this presentation. In my presentation, I will focus on four major issues. First, I would like to give you an overview of CCHF, then bringing up you up to date on geographic distribution and emergence of CCHF. Thirdly, I will go on to highlight what I see as the main points of the treatment of the disease. And finally, I would like to address strategies for prevention of Crimean Congo hemorrhagic fever. So let me first give you a brief overview of the disease. Crimean Congo hemorrhagic fever is a tick-borne zoonosis. Viral hemorrhagic fevers share many common features. In general, early signs and symptoms can include fever and hemorrhage associated with thrombocytopenia. Infection in humans typically occurs via tick bite or from contact with the blood or tissues of infected livestock. Nosocomial infection is an important problem in endemic countries, especially there are reports from Pakistan, Iraq, Turkey, Russia, India, and Spain. These regions have the common features that hot, dry summers with cold and moderate rainy winters. Land structure is more fragmented, and agriculture, backyard farming, and animal husbandry are common. This habitat is favorable for tick survival. When the vegetation structure is associated with livestock grazing, CCHF is mostly seen in people working in animal husbandry and agriculture. In Turkey and also in the northern hemisphere, more patients are seen in the summer months from April to September with a peak incidence in June and July. CCHF is found in over 30 countries in Africa, Asia, Eastern Europe, the Balkans, and the Middle East. In the past years, the virus appeared in the new areas such as India and Spain. So, just over the 2 decades, Turkey, Greece, Georgia, India, and Spain have reported their first cases. Now, let's take a closer look at the epidemiology of Crimean Congo hemorrhagic fever in Turkey. The first cases of Crimean Congo hemorrhagic fever were reported in Tokat province in May 2002. In the following years, despite awareness and mass education campaigns, the number of cases rapidly increased, and the disease spread horizontally to the neighboring cities which have a similar climate. The climate of this Anatolian region have optimum climate for survival of the hemorrhagic population. Why Crimean Congo hemorrhagic fever is emerged? There are several hypotheses. Increase in temperature due to climatic change facilitates the proliferation of tick populations, and global warming may lead to geographical expansions in the northern hemisphere. Other key drivers of the emergence of Crimean Congo hemorrhagic fever in a new region are animal movements, increase in number of tick-susceptible animals, and increase in tick population. Now let me briefly summarize the main factors for spreading Crimean Congo hemorrhagic fever. These are the illegal movements of animals seen especially on the borders of Afghanistan, Pakistan, and Iran are related in the emergence of new outbreaks in the region. The other factors are human travel and transport and trade of live animals harboring infected ticks. And another important factor may be migratory birds. We investigated migratory birds' role in spreading Crimean Congo hemorrhagic fever virus through attached ticks. We detected CCHF virus RNA in ticks of migratory birds. Two isolates shows similarity with Crimean Congo hemorrhagic fever virus genotype 4, suggesting a role for ticks in CCHF epidemics in Turkey and spread of the virus by birds. Turkey is on the path of Black Sea Mediterranean flyway of migratory birds, which crosses the Crimean Peninsula and the Black Sea to Africa. It seems most likely that the spread of virus by migratory birds. This is the distribution map of the 4 migratory bird species detected carrying ticks with Crimean Congo hemorrhagic fever. There is an overlap between the Crimean Congo hemorrhagic fever endemic areas and breeding and wintering grounds of migratory birds, suggesting a potential role of migratory birds in carrying and spreading Crimean Congo hemorrhagic fever virus harboring ticks. Another important factor is Eid al-Adha. Eid al-Adha is celebration of sacrifice. It's a Muslim festival. People sacrifice acceptable animals such as sheep, goat, camel or cows by themselves and then share meat with poor people. So the festival, given the increased contact with animals, that threatens to increase the number of infections. Outbreaks have been reported during this festival in Pakistan. Nowadays, it takes place in the summer months that CCHF is more prevalent. Therefore, there's a potential risk of new outbreaks in our region. Overall, 12 travel-related cases reported worldwide, and according to PROMET, there were 9 infected cases traveling from Afghanistan to Pakistan, but the actual real number may be more than 9 in that area. There's a low transmission risk for travelers except for animal researchers, healthcare workers, hunters, and adventure travelers. And the mortality rate of Crimean Congo hemorrhagic fever differs in various regions and medical centers. And it is dependent on virus virulence, immunological condition of the patient, the possibility of early diagnosis and treatment, and the quality of supportive treatment. Thus, the mortality rate of Crimean Congo hemorrhagic fever is very variable from as low as 4% to more than 80%. In those endemic countries, the case fatality rate is around 4% to 12%. Also, there's one report from Kazakhstan. The case fatality rate reported as 15%. Viral load is main predictor of Crimean Congo hemorrhagic fever infected patients who died appear to have a higher viral loss. Low viral loss correlated with IgG detection. Also, it was shown that the viral load is significantly associated with mortality. Here are the independent predictors of the mortality. It includes presence of hemorrhage, particularly gastrointestinal bleeding and hematuria, impaired consciousness, diarrhea, splenomegaly, and also there are some laboratory factors: thrombocytopenia, leukocytosis, prolonged APTT, and increased aminotransferases. So, how can we treat these patients? Given the lack of specific treatment or vaccine against the virus, the standard treatment of CCHF is intensive monitoring and supportive treatment. Red blood cells, platelets, and fresh frozen plasma transfusions may be necessary. Unfortunately, in some countries, especially in rural areas, there is limited access to blood and blood products. To meet the need for an adequate, safe, and timely blood product supply, the blood systems in developing countries should be improved. So, platelet transfusion is warranted to maintain platelet count above 15,000 in the setting of bleeding. And for patients with platelet count below than 20,000 in the absence of bleeding. Also, we need cautious with unnecessary interventional procedures to minimize the risk of bleeding. And in cases of if the prothrombin time or INR 1.5 times the upper limit of normal or APTT upper limit of normal, we can give fresh frozen plasma to the patients. So the data are insufficient to support routine use of steroids, intravenous immunoglobulin or plasma exchange, and also use of hyperimmunoglobulin prepared from the plasma of donors which antibody against CCHF requires further study. So there is no proven antiviral treatment for Crimean Congo hemorrhagic fever infection. The debate is still ongoing around the use of ribavirin. So why there's a debate? Because it is difficult to interpret results of those studies. Most of them are observational, most of them, except one, are retrospective studies. Calculation of an adequate size is critical. Different study designs, lack of randomization, severity of infection varies. Viral load is not available in most studies, and also there is a variation in medical practices. So, the clinical efficacy of ribavirin in the treatment of Crimean Congo hemorrhagic fever cases were contradictory, and more case control, randomized control trials are required to confirm the efficacy of ribavirin in the treatment of Crimean Congo hemorrhagic fever according to these meta-analyses. And also this systemic review supports that the need for definitive therapeutic agents. So these recommendations were not addressed in its recent management of viral hemorrhagic fever guidelines. The use of ribavirin, though not officially recommended by WHO, ECDC, and CDC. So there's a Turkish sentence. It is important to move past the ribavirin debate and focus on the detailed screening of additional candidate therapeutics. So the Turkish sentence is, what word that belongs to yesterday, it is gone. My loved one with yesterday. Now it is time to say new things. It is said by Rumi. So the data indicate that favipiravir has efficacy against Crimean Congo hemorrhagic fever in vitro and in vivo, and also in a non-human primate model of infection. So these data suggest that favipiravir may be an effective antiviral for the treatment of advanced Crimean Congo hemorrhagic fever. In brief, there is no vaccine or an approved antiviral therapy is available. And as I mentioned before, there is a debate over whether ribavirin is needed to treat Crimean Congo hemorrhagic fever. So there is more modern approach such as mRNA, DNA vaccines, recombinant viral protein-based vaccines, and virus-like particle vaccines are under development. Now, let's move on to the last topic of my presentation. Early recognition is critical to controlling the spread of viral hemorrhagic fevers, especially identify the cases. Rapid diagnosis is essential for prompt implementation of appropriate infection control. Standard contact and droplet precautions for suspected cases with viral hemorrhagic fevers are recommended to prevent transmission. Standard precautions are necessary to prevent nosocomial transmission of viral hemorrhagic fever viruses. So these patients should be placed in private rooms or these patients should be cohorted. In general, establishment of effective surveillance systems within at-risk regions and adequate preparation for disease management are essential. Networking and training play pivotal roles in sustaining a rapid and effective response to Crimean Congo hemorrhagic fever. International collaboration can provide scientific support, training in the diagnosis of Crimean Congo hemorrhagic cases, expert consultation, and the exchange of experiences and protocols for management of disease with One Health approach. Also in 2016, Crimean Congo hemorrhagic fever was listed as a WHO priority pathogen for which urgent research and development. And future research need to reduce spread of Crimean Congo hemorrhagic fever. Early rapid diagnosis of Crimean Congo hemorrhagic fever is gaining increasing importance in health programs. Therefore, we need a standard case definition for Crimean Congo hemorrhagic fever surveillance. Development rapid diagnostic tests is critical. Also, there is insufficient reliable evidence to show whether ribavirin is effective in treating Crimean Congo hemorrhagic fever. Now, I would like to summarize the main points. Crimean Congo hemorrhagic fever is an emerging zoonosis. The global incidence of Crimean Congo hemorrhagic fever is increasing due to climate change, animal movements, and movements of migratory birds. And also, there is no approved antiviral drug for treatment and vaccine for prevention. And early diagnosis of the disease is fundamental. Risk assessment of emergence of zoonotic disease is essential. And also, One Health approach is needed to fight against in the threat of Crimean Congo hemorrhagic fever. Thank you very much for your kind attention.